Okay, this is 6 months post-extraction PRF placement. That's all we placed in the socket was platelet-rich fibrin and then covered it with a resorbable collagen membrane. Note that there is minimum, if any, vertical bone loss, and the alveolar crest is almost perfectly flat. PRF alone in combination with a resorbable collagen membrane, and that's formed an ideal implant site. So I've got a nice flat alveolar crest and I've got approximately 10.5 millimeters of bone. Now the shortest implant, unless you use one of the fat implants, is, and you want to stay about 2 millimeters from the bone. So this is plenty of vertical space for a root form implant. When you make your incision, be sure you incise on the lingual. Don't incise down the middle of the socket, because if you do, you're going to have to reflect 2 flaps. You only want to reflect 1 flap. So I'm incising from the mesial lingual to the mesial lingual of these 2 teeth, and then I'm going to make my incision in the sulcus around these teeth and reflect it just enough to expose the alveolar crest. The other thing to remember is you've got the middle foramen down here with the middle nerve, and so don't be cutting or retracting or placing a lot of pressure in the region of the middle nerve. The patient could end up with a numb lip. Look at that. That's only platelet-rich fibrin was placed in that socket and with membrane on top of it. And look how dense that bone is after 6 months. You got to let it heal for 6 months. 3 months is not enough. It takes bone 6 months to heal in an extraction site. And you must bone graft it with either bone graft material or platelet-rich fibrin, which I like better, and not look like a swayback horse. You want a flat alveolar crest, and look what we got. So that's perfect. Now I'm using this long shank round burr to make a little divot which will hold my pilot drill, and also let me look at the occlusal surface to be sure I'm exactly where I want to be placing that implant. Now you'll notice I don't have a cone beam radiograph. I'm going to show you another technique that's very, very specific, but you don't have to use a cone beam. We're going to use a pilot drill. I'm just creating that little divot, and then I'm going to look at it and be sure it's in the right spot. Now I'm going to measure, I measured on my digital radiograph, 10.6 millimeters. So I'm going to take a pilot drill and put an endo stop on the pilot drill and measure that. Now that's 10 millimeters. So I'm going to go about 9 millimeters into the bone with the pilot drill, and then I'm going to take a radiograph. And you can see, here's the nerve right here. I've got plenty of room. There's the middle foramen. You can see I'm in good shape right here at that depth. So I'll probably go to about this depth. And I'll measure from here to the rubber stops on my pilot drill. And in this case, I know that I'm perfectly good at 12 millimeters. That was 14 millimeters from alveolar crest to the tip of the pilot drill. So I'm going to go back 2 millimeters and use a 12 millimeter drill. This is the dentist system. There may be another system like this. We don't take any money from dentists, but I love this system. The reason I love it, each of these drills has a shoulder on it at this length, 14, 12, 10, and 8. So once you establish your working depth, all you have to do is use a different drill. See, this is 2.2, 2.8, 3.7, 4.1, 4.3, 4.8 in diameter, and just go right down the line. I hate those drills that are silver with the black lines on them, because when they're spinning and you've got water and saliva and blood, you can't keep up with the black line and you can't be specific. This is perfectly specific. The only hard part about this is establishing your pre-drill vertical depth, and you do that with the pilot drill with the rubber stoppers. Then once you've established that, just boom, 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 boom. And the width of the drill obviously depends on the width of the alveolar crest. You want at least 1 millimeter of bone, facial and lingual, to your drill or to your implant. You don't want to drill the hole all the way out to the extent of the facial and the lingual dimension of the alveolar crest. You want at least 1 millimeter on the facial and the lingual if possible. If you go past it, you may have to bone graft. And you want to align this with the teeth on either side, both lingual facially and mesial distally. And then I'm going to take another periapical radiograph of this drill. And you can see here's the tip of this tooth right here, and the tip of this tooth right here. Here's the inferior alveolar nerve right here. So we've got plenty of space. Then you're just going down the line, and I take the periapical radiograph with the drill in the osteotomy. And then you can use the top part of the drill to be sure you're in ideal alignment. See, so I go till that sleeve or that shoulder contacts the alveolar crest, and I know that's exactly 12 millimeters. It's perfect. See, and now we're going to the next one. And then I'll leave the drill in the osteotomy and just look at the top part of the drill and be sure it's in the same long axis as this tooth or this tooth. Now this tooth is tipped a little forward, so I'm mainly going with the second bicuspid. Now remember, I'm able to use these wider drills because I've got a wider alveolar crest. But I'm paying attention to be sure I've got at least 1 millimeter of bone on the facial and the lingual of the drill. Another thing to remember is the mandibular bone is a lot harder than the maxillary bone. So the hardest bone in the mouth is the mandibular anterior. The second hardest is the mandibular posterior. The third hardest is the maxillary anterior, and the softest bone in the mouth is the maxillary posterior. So this is a harder bone than that bone in the maxilla. So here we go. I've got an extender on here now, so the handpiece doesn't bump the adjacent teeth, and I'm able to use the largest drill. Isn't that amazing? With that platelet-rich fibrin. Now, I personally like to place a collagen resorbable membrane over the platelet-rich fibrin when I'm preserving a socket, just because I've got a flat surface when it heals. So there's the osteotomy. Here's the implant. This tells you what you're going to use. If you get to this drill, you're going to use a 4.8. Now, in the maxilla, you're going to use a larger implant than drill. In other words, if you end up with this drill, you may use this implant because the bone is so soft. But in the mandible, you're going to use the same implant as the size of the drill. Now the 35 Newton centimeter situation is kind of interesting because as long as it's screwed in well, as long as it's tight, we're not loading it for 3 months. And so as long as it's tight, even if you don't quite get 35 Newton centimeters of torque, but you're placing it into a flat alveolar crest with lots of alveolar process, it doesn't have to be 35 Newton centimeters if you're not loading it right there. You want it to be tight, but say you got 25 and it was really tight. You'll be fine because it's going to heal for 3 months before you load it, and that last little bit of bone will grow into or osseointegrate with the implant, so you'll be fine. And you'll be able to finger tighten it to a point and then have to use your ratchet wrench. The thing I love about this is so specific. If you're using those silver drills that don't have a shoulder, you may be a little bit off on your depth. With these, the depth is perfect. As you can see, I'm 35 Newton centimeters of torque here, which is perfect at 12 millimeters. And here's the healing cap, and these are just bone level healing caps for 3 months. It's just perfect. Then 3/0 gut suture. And you will have primary closure. Remember, you're reflecting the flap from the lingual, so you're just having to reflect one flap. You can see we're sutured over here on the lingual. Now, not so far to the lingual that you take a chance on damaging the lingual nerve, but I'll put 3 interrupted suture. All right, so extraction of a mandibular molar tooth, socket preservation with platelet-rich fibrin, and then implant placement 6 months later. That's the dental minute.